Alex. I'll be showing you how to set up for a knee x-ray. So we start with our IR in the table bucky, and you want to make sure you detent to the middle of the table. We want to have our collimation set for 10 by 12, and then you want to line up the crosshairs with the center of the bucky, and the SID is 40 inches, which I'm set at now. Okay, so for the console setup for a knee, you're going to choose the correct patient, and right now we're just doing AP lateral and medial oblique. So for all three of those, a technique of 70 kV at 5 mass would be acceptable. Hi, how are you?
I'm good, thank you.
Good. My name's Alex. I'll be doing your x-rays. Could I have your first and last name?
Yes, it's Petunia Picklebottom, 5'5", 1995.
Perfect. And then is there any chance of pregnancy for
No.
you? Okay, so what brings you in today?
I fell going up the stairs a week ago, and
Okay.
I hurt my knee really bad.
With which knee was it?
My left knee.
Okay. I'm just gonna have you change into this gown from the waist down, and then we'll take some x-rays for you. With AP, medial, oblique, and lateral projections of the knee, I have my patient here, supine, in the supine position. And from before, I already lined up my bucky with my tube. And it's her right knee that hurts, so we're going to move the table, because you never want to move the tube after you've lined it up. So, can you just scoot your leg a little bit quickly? Perfect. So the central ray is 1/2 inch below the patellar apex, which is like the bottom of the patella. And my patient is small. She probably has a pelvis between 19 and 25 centimeters, so the angle for the AP is going to be perpendicular, so no tube angle. And also I'm just going to collimate down a little more for her because she is on the smaller side. Okay, put your right marker for the right leg and make sure always to shield. For females, just try to get the breasts and the, I'm gonna, from this position, just go into a medial oblique position, and you never want to rotate just the foot. Make sure you log roll her entire leg. So now it's a little off center, so I'm going to move it just like this. A little bit more. And you want to make sure you're at a 45-degree angle. And the oblique also isn't going to have a tube angle because of my patient's size. If it was larger or really tiny, like child patient, then you would add a tube angle dependent on that. So I don't know if you can do any more. Okay, so that's good, and I'm going to do a technique of 70 kVp at 5 for this projection. Okay, and then always shield and to the marker. Okay, so for the lateral, I'm going to have you roll on your side facing my direction, and then you can put your unaffected leg in front. Okay, I'm going to put this on again. Still, the central ray is at the apex of the patella, 1/2 inch below. And I'm going to open the collimation a little bit back up for this one. Okay. And it's always better to have the femur going with this line. It just makes the image come out better. And then bend the knee about 20 to 30 degrees, and that opens the joint space really well. And then always for the lateral knees, you need to add a tube angle of about 5 to 7 degrees. So then with that, I need to reline up my bucky. Just make sure this foot's out of the way. Yeah, and then move her back down. Okay. Do the tunnel view, which is also the intercondylar fossa. I'm going to start with my patient prone on the table. I'm gonna have her put the affected leg up onto this surface. Make sure that the knee is nice and centered onto the IR. I'm going to make this size smaller, so it's only entering right here at the popliteal surface on the back of the leg, and the central ray is angled about 40 to 50 degrees, but really you just want it to be perpendicular with the lower leg, the tibia and fibula. Make sure that this is centered, and make sure you have a free cassette chosen on your console. And I'm going to take this image at 70 kV and still about 5 Mass. And of course, never forget to shield the patient. Okay, now we're ready to go. Knee projection, we're going to do a picture of the patella, and we're going to choose the Settegast method. So the SID is going to be about 40 inches back from the patient's knee, which I already pre-measured. And then you're going to always have the shield, of course, and then you're going to ask your patient to hold this IR for you for the projection. So I'm going to have you tilt your leg just like this, and you can see that it's just going to turn out being a nice image of the patella. The size of the collimation is about 4 by 4 inches, and the CR is going to be perpendicular to the patellofemoral joint. So the angle of the tube depends on the person, and hers is actually, I'm going to actually do a small angle down. I'm going to go about 5 degrees just to make it more perpendicular, and then I'm going to enter it like so. Okay, now you can see that it's nice and perpendicular. Again, I'm going to use a smaller technique for this one, so about 60 at like 3. Then always have your marker, and you're ready to go. The AP knee projection, and it is shown well that there's no rotation, that the leg was going straight on. You see the intercondylar eminence very well, and you see the tibiofemoral joint space very well also. This is the lateral knee. This isn't a great example of it because it needed a tube angle of 5 to 7 degrees in order to superimpose these condyles of the femur, but the patellofemoral joint space looks good, and the rotation looks pretty good as well. This is the sunrise view of the patella. This is a very good image. It's centered well, and the joint space is very open. And this is the tunnel or intercondylar fossa view, which shows this space right here. And that is also done very well because this space right here is open. This is an AP oblique view of the knee with medial rotation, which is shown by the location of the patella on the medial side and the open proximal fibular tibia joint.